our patient, he had an episode of seizure. So just enumerate few of the conditions quickly.
Be due to TB meningitis.
Okay.
It could be due to toxoplasmosis. It could be due to progressive multifocal
PMLE. Okay.
Then it could be due to CNS.
So why this is important to note these?
Opportunistic infections.
Yeah, because many of these HIV patients, they can present with basically these opportunistic infections, and they seizure may be the presentation in most of them. Okay, so that's why it is important.
Despite being on broad spectrum antibiotics, he continued to have multiple spikes of fever, and also his ascites and pleural effusion was worsening. His biochemical investigations revealed a worsening of pancytopenia, with hemoglobin had dropped down from 9.3 to 7.8, TLC had dropped down to 1800 cells per cubic millimeter, and platelet count had decreased to 48,000. His peripheral blood smear had revealed toxic granules, and his sputum for culture had revealed was positive for MDR Acinetobacter and Klebsiella. Repeat CCD chest and abdomen had revealed bilateral pleural effusion with central lobular nodules and mediastinal lymphadenopathy, splenomegaly, and gross ascites. This is a chart showing the cytopenia trend as his hemoglobin, TLC count, and platelet count had worsened up to day 30 of the treatment. So finally, we had a patient with who was a known case of immune surveillance with disseminated MDR TB with severe PCP pneumonia and a polymicrobial carbapenem resistant pneumonia, and his evaluation for fever with pancytopenia was still pending. He was continued on antibiotics, and since he was still febrile with, despite being on broad spectrum antibiotics, antifungal was also added. He was switched to second line ART, and he was transferred to Command Hospital for further management. At CHSC, he continued to have on and on episodes of fever with persistence of pancytopenia. His repeat CD4 count was 62 cells per microliter. At this age, with the possibility of fever and pancytopenia, the differentials were considered. For fever, the differentials were possibility in the background disseminated MDR TB or a central line bloodstream infections, sepsis, and HLH. And differentials of pancytopenia were considered secondary to hypersplenism in view of splenomegaly, drug history related to Septran or cycloserine related folate deficiency or ART, advanced HIV leading to bone marrow fibrosis or a secondary HLH.
So these are the causes of bone marrow suppression in HIV. So since this patient has been exhibited to ART, so this thing was also kept in mind. Next.
He was evaluated for pancytopenia with PCR for CMV revealed less than 1,000 copies. PCR for parvovirus was negative. Serum cryptococcal antigen was negative. In view of persistent ascites, ascitic fluid analysis was done, which revealed low SAG ascites with WBCs of 110 cells per millimeter cube, which were predominant lymphocytes. Now I'd like to call my pathology colleague to discuss the findings of bone marrow and peripheral blood smear.
So even at this point, we are clueless about the diagnosis, what is the cause of pancytopenia. So we have gone ahead with the bone marrow aspiration as well as biopsy.
Good morning, everyone. I'll be showing peripheral blood smear, bone marrow aspirate, and bone marrow biopsy of this patient. So in the peripheral blood smear, we comment upon the morphology of RBCs, WBCs, and platelet. The peripheral blood smear showed normocytic normochromic RBCs, mild anisopoikilocytosis seen in the form of teardrop cells. There were no any NRBCs seen. Coming to the WBC, neutrophil shows prominent granules as highlighted in the image. Mild left shift was also noted in the form of myelocytes. No any atypical cells were noted or no any blasts were seen in the peripheral blood smear. Platelets were reduced on the peripheral smear. So final opinion was given as pancytopenia, as hemoglobin of the patient was 11.1 gram. Absolute neutrophil counts were 2,000 and platelets were reduced on smear 80,000 to 90,000. Moving on to...
Jasprit, can you tell what is left shift for the benefit of all of us.
Sir, left shifted when we see any immature WBCs on the peripheral blood smear, sir.
And teardrop cells you have also mentioned. So,
So teardrop cells can be seen in the anemia, in the thalassemia, in myelofibrosis, as well as in vitamin B12 deficiency. So moving on to bone marrow aspirate. The aspirate was particulate and cellular. Trilineage hematopoietic elements were seen. Erythroid series were adequate in number and shows normoblastic maturation. No any significant dysbiosis noted. Myeloid series were showing normal maturation and differentiation up to neutrophils. No any increase in blasts were seen. This is the megakaryocyte, which were adequate in number and showing normal morphology. No any dysbiosis noted. There were increase in plasma cell around 7% in this case, which could be reactive. On higher magnification, on Leishman gem sustain, bone marrow aspirate smear showing evidence of hemophagocytis. As you can see in the image, there is a histiocyte and it is engulfing the blood elements, including red blood cells, normoblasts, and platelets. We also appreciated few ill-formed epithelial granulomas in this case. We received fragmented bone marrow biopsy showing only 3 to 4 intratrabecular spaces, which was adequate bone marrow biopsy and shows overall cellularity of 40 to 50%. Trilineage elements were noted in the submitted biopsy. Erythroid series shows normoblastic maturation and myeloid series shows maturation up to neutrophils. Few scattered megakaryocytes were also noted. Few foci in the biopsy showed hemophagocytosis and scattered increased plasma cells. On further performing Z stain, there were no any acid-fast bacilli seen. So final opinion was given of granulomatous inflammation with hemophagocytosis and plasmacytosis.
so can I have any path resident? So just tell me what are the cause of granulomas? Just enumerate.
Sir, granulomas in the bone marrow can be seen in the chronic bacterial infections,
Just cause, enumerate the cause.
the tuberculosis, brucellosis, and in viral infections and sarcoidosis, and in hematolymphoid malignancies like
Any foreign material can cause surgical?
talc sutures. Sir.
Sutures, very good. Okay. So another one was the final opinion was plasmacytosis. So what is reactive plasmacytosis?
Reactive.
Next to you, anyone else? What is reactive plasmacytosis?
Sir, plasmacytosis is when the percentage of plasma cells is more than 5%. It can be due to various causes. It can be due to plasma cell dyscrasias or reactive causes. Reactive causes being infections like tuberculosis. It can be.
You have not told about what is reactive plasmacytosis. What is the definition of reactive? Anyone, any path resident can take?
Percentage of plasma cells when it is
No, Jasprit, what is reactive
Sir, when
plasmacytosis?
normally plasma cells should be present in bone marrow 1 to 3%, sir. When the plasma cell increase more than this percentage without any malignancy, it is called reactive plasmacytosis.
Okay, so based on all those clinical and this input, what do you think? What should be our diagnosis in this case?
Sir, as the patient is suffered from fever, splenomegaly, and there was also evidence of, as I read in the sir case, the serum ferritin level was high, sir, and patient was having on bone marrow. We have found evidence of sir HLH as well. So on that basis, our criteria is fitting into the sir HLH.
Secondary HLH.
Secondary
And what are the cause for secondary HLH?
Sir, in the secondary HLH, there can be it can be associated with immunocompromised patients, sir, and HIV and any autoimmune diseases. Sir.
Okay, fine. Thank you.
Thank you, sir.
Yeah, Abhishek.
Considering the marrow finding of HLH, he was evaluated and his serum ferritin levels were raised. His serum fibrinogen levels were less than 1.5 gram, and he had pancytopenia with bone marrow aspiration. And in background clinical picture of fever and splenomegaly, he was considered as case of secondary HLH. This was the initial HLH 2004 criteria, where either one or two, they based on molecular diagnostic criteria or a diagnostic criteria out of these 8, only out of 5 had to be required to diagnose it. There has been a recent revision for the 2024 criteria which has come in. However, it has been recommended for only familial HLH, out of which either a molecular diagnostic criteria for HLH in background picture of signs and symptoms. Second is the cellular findings on a marrow, or third is the clinical criteria, out of which 5 out of the 7 are required. HLH.
So coming to this HLH, it's a life-threatening conditions which is characterized by uncontrolled and ineffective immune response, and it can lead to severe hyperinflammation and fatal multiple organ damage. So the types, it could be primary and secondary. Like in our case, it was secondary and could be because of infections, malignancy triggers, and other like immunocompromised and transplanted patients, it can be seen.
The treatment for secondary HLH is essentially to search for the triggers and evaluate the cause. However, we can still treat with steroids or IVIG for management of HLH. So our patient was started on tablet dexamethasone 4 milligram BD, following which his hematological parameters had improved. His hemoglobin had increased to 12.1 from 10.6 in around 15 days. His TLC count had improved to 3,100 and his platelet count had improved to 1,05,000. His appetite had improved. He had gained weight of about 5 kg over 3 weeks of